In just 10 years, certain cosmetic genital surgeries have spiked by an astonishing 600%.
Yeah, it's a massive jump, truly.
Right. But beneath the sensational headlines and the cultural taboo, there is this world of just rigorous fractional mathematics.
Math that you really wouldn't expect.
Exactly. Because usually when we think about restoring a delicate structure, I mean, like an old suspension bridge, there's this expectation of unforgiving precision. You don't just pour a truckload of concrete and hope it holds.
Right, you need those millimeter-perfect calculations at exact load-bearing points.
Yeah, but then you step into the world of cosmetic medicine, and the public perception completely shifts. People imagine it's just about inflating things, like pumping in volume until a space just looks a certain way.
Which is such a dangerous misconception.
It really is. So today, we're going to look at a field where that architectural precision is not just preferred, it is absolutely critical for physiological safety. We are doing a deep dive into the rapidly expanding world of cosmetic gynecology.
Specifically, we're looking at the exact clinical science and the crucial dosages of dermal fillers used for labia majora augmentation.
Okay, let's unpack this. Because it's a topic that has seen massive global growth, right?
Yeah.
But it's rarely discussed with the clinical seriousness it actually demands.
No, it isn't. And when you look at our sources for this deep dive, I mean, we're pulling from clinical studies in the Surgical and Cosmetic Dermatology Journal, along with case studies from pharmaceutical companies like Toledo Pharma.
Plus safety guidelines from the UK Parliament and the MHRA, right?
Exactly. And treatment protocols from leading international aesthetic clinics. And a very clear picture emerges from all of this.
Which is that the success of this procedure relies entirely on the practitioner's deep understanding of vulvar vascular anatomy and tissue physics.
Yeah, tissue physics is key because the labia majora, the outer lips, they basically act as a protective cushion.
Right, and I was reading through the notes from the Kedoming Clinic, and what struck me wasn't just the demographic of menopausal women seeking this out. They see younger athletes coming in, too.
Oh, yeah, equestrians, cyclists.
Right, because of severe chafing. It seems like a significant portion of this isn't about how the tissue looks, but how it functions as a literal barrier.
What's fascinating here is the stark contrast with something like facial fillers. You know, when someone gets filler in their cheeks or lips, the goal is almost entirely aesthetic. Enhancing projection or smoothing a contour.
Yeah.
But intimate fillers often serve to restore a literal physiological barrier. Over a woman's lifetime, due to aging, the natural decline of estrogen in menopause, childbirth, or even significant weight loss, the labia majora can suffer from severe atrophy.
It essentially deflates.
Exactly. The tissue loses its natural volume and elasticity, and that plumpness is biologically required to protect the intervaginal tissues, like the labia minora, from chronic dryness, mechanical friction, and severe irritation.
Okay, but I have to challenge this premise just a little bit, though, because the beauty industry has a very long, very profitable history of pathologizing perfectly normal aging.
Sure, absolutely.
So are we looking at a legitimate restorative treatment for tissue degradation, or is this just, I don't know, a modern cosmetic trend driven by completely unrealistic visual standards?
Well, the visual and societal pressures are undeniable, and it would be naive to ignore them entirely. But when you examine the clinical data, the primary metric of success for many of these patients isn't visual symmetry.
What is it then?
It's the cessation of physical pain. For menopausal women experiencing genitourinary syndrome, the loss of estrogen doesn't just cause a cosmetic deflation, it causes the structural matrix of the tissue to literally collapse.
The protective cushion disappears.
Right. And restoring that lost volume provides tangible, measurable relief from the physical shear stress that occurs during exercise or intercourse. It is a functional restoration that just happens to utilize cosmetic tools.
But a 600% spike, I mean, surely they aren't all marathon runners and equestrians seeking functional relief.
Well, no, they aren't. But you also have to factor in that for decades, women simply suffered through genitourinary syndrome in silence because non-surgical options didn't really exist.
Oh, I see.
Now that a minimally invasive 30-minute clinical solution is available, this latent demand is simply surfacing.
That makes the mechanics of this incredibly important then. Because if the goal is to rebuild the highly functional load-bearing cushion, a practitioner can't just inject filler randomly, right?
Definitely not.
So how do doctors mathematically calculate the exact amount of filler needed to restore this specific anatomy without completely overdoing it?
That is where the science gets incredibly meticulous. In the Surgical and Cosmetic Dermatology Journal, researchers developed a systematized approach called the vulvar anatomical vector technique.
The vulvar anatomical vector technique.
Oh,
Right.
yeah. The tissue is mapped out into 5 specific anatomical structures, or vectors, and the dosage for each vendor is measured in fractions of a milliliter to ensure safe, reproducible results.
Walk me through the physics of these vectors, because looking at the dosages in the source material, the margins for error seem razor thin.
They really are. Let's start deep inside the tissue. The first vector is VA1. This is the medial border, deep in the fat pad.
Okay.
Practitioners inject between 1.0 and 2.0 milliliters here. VA1 is effectively the anchor point. Its primary physiological goal is to promote coaptation.
Coaptation meaning the mechanism that actually brings the structures together to close the gap and protect the inner anatomy.
Yes, exactly. You need the highest volume there, up to 2.0 milliliters, because it is doing the heavy lifting to bridge that physical space.
Right.
But as you move outward to the lateral vectors, which are VA2 and VA3, the math tightens dramatically. These are injected into the deep fat pad for anterior projection, which brings the tissue forward.
Okay, and what's the dosage there?
VA2 gets just a zero point 0.6 to zero point 0.8 milliliters, and VA3 gets a minuscule zero point 0.4 to zero point 0.6 milliliters.
Wait, why does the dosage drop off so sharply just by moving slightly to the outer edge? What happens physically if a doctor just pumps 2.0 milliliters into VA3?
If you over-inject the lateral edge, the tissue doesn't push together to form a protective seal. It just pushes outward into the thigh.
Oh, wow.
Yeah, you widen the structure uselessly and cause visual distortion rather than projecting it forward for protection. That's why the lateral borders only receive fractions of a milliliter. It's all about directional force, not just filling up a space.
So it's not like simply inflating a balloon with a single pump of air. It's more like architectural scaffolding. You need precise fractional milliliter measurements at exact load-bearing points to rebuild the structure without it collapsing or bowing outward.
That is a perfect analogy. You are rebuilding a supportive, three-dimensional matrix. And that brings us to the superficial vectors.
VA4 and VAS, right?
Right. VA4 targets the superior area blending into the mons pubis, receiving 0.5 to 1.0 milliliters. And then there's the VAS vector, the surface. This is another 0.5 to 1.0 milliliters injected very superficially into the subcutaneous tissue.
I imagine injecting too much volume close to the surface is a total recipe for disaster.
It is. The deep vectors handle the structural projection. The superficial VAS vector is strictly to increase tissue tone and smooth out skin wrinkling.
Got it.
If you put high volumes of hyaluronic acid superficially, you don't get structure, you get visible, unnatural lumps.
Yikes.
Yeah. And because of these distinct architectural roles, the study establishes a strict hard limit. No more than 3.0 milliliters should ever be injected into each side of the labia majora in a single session.
Okay, so a standard starting point might be 2.0 milliliters per side, with 3.0 milliliters serving as the absolute ceiling to avoid distortion or complications.
Exactly.
Well, I was reviewing a real-world case study from Toledo Pharma involving a 56-year-old woman suffering from genitourinary syndrome of menopause. The practitioner in that case ended up using a total of 6 milliliters of hyaluronic acid filler.
Which perfectly aligns with the clinical maximums, provided that dosage is divided evenly.
Hold on, I thought the absolute ceiling was 3 milliliters. Did they break their own clinical rules for this specific patient?
No, it's 3.0 milliliters per side. So a 6 milliliter total is the absolute maximum allowed in a single session for the entire procedure.
Oh, I see.
In this specific case, the patient had such severe vaginal atrophy and significant volume loss that the practitioner had to push the dosage right to that absolute edge. To provide adequate protection and alleviate her symptoms, they needed the maximum allowable structural load.
And what exactly is bearing that load? Because let's talk about the specific hyaluronic acid formulations. The chemistry here is tailored specifically for this high-friction environment, right?
Definitely. The environmental stress on this tissue is immense, so standard facial fillers simply don't hold up. The sources detail specific HA fillers like Deserial, which includes an ingredient called mannitol.
Mannitol.
Yeah, it's an antioxidant found naturally in things like raspberries and celery.
Wait, what is an antioxidant doing in a dermal filler?
Well, when a needle or cannula enters the tissue, it causes localized trauma, and that releases free radicals. Those free radicals cause immediate oxidative stress that attacks and breaks down the newly injected hyaluronic acid. The mannitol is added to essentially sacrifice itself.
Oh, wow.
Yeah, it neutralizes the free radicals, significantly reducing post-injection swelling and allowing the HA matrix to survive much longer in the tissue.
That's brilliant. I also saw a product mentioned called Neuvia Rose, which takes a totally different chemical route. Contains amino acids like glycine and L-proline.
Right, and those are the fundamental building blocks of collagen. The logic there is that the filler isn't just taking up space, it is actively feeding the local fibroblasts.
Encouraging the body to rebuild its own structural proteins over time.
Exactly. Generally, these specialized HA fillers will maintain their structural integrity for maybe 6 to 18 months before the body naturally metabolizes them.
Which brings up a good question. If these HA fillers dissolve after 18 months, isn't there a permanent solution? Why not just use autologous fat transfer? Like taking fat from the patient's own thighs or abdomen and moving it to the labia.
You certainly can, and many do, but the clinical math changes drastically because of how the body reacts to transferred fat.
How so?
When you use a pre-measured syringe of HA filler, what you inject is exactly what stays. If you map out 2.0 milliliters across those vectors, you get exactly 2.0 milliliters of structural volume.
Very predictable.
But with a fat transfer, the body naturally reabsorbs about 20% of the transferred fat cells over the first few months because they lose their blood supply during the move.
Ah, so essentially, using HA filler is like installing a highly engineered water-retaining sponge that immediately restores the barrier.
Yes.
But fat transfer is more like planting seeds. The surgeon actually has to intentionally over-inject, planting 20% more fat than they ultimately need because they know a portion of it just won't survive the winter.
That perfectly captures the biomechanical difference. The surgeon has to calculate that expected loss into their initial surgical plan, making fat transfer a slightly less predictable process in the immediate aftermath, compared to the exact fractional measurements of HA fillers.
Makes sense.
However, the fat that does establish a blood supply and survives becomes a permanent living part of the tissue.
And we should probably briefly add some context regarding the financial reality of these options for you listening. These highly precise treatments require a significant investment.
They are premium medical procedures, absolutely.
Yeah, looking at clinics in the UK, a standard 2 milliliter HA treatment costs around £825. And if you require the maximum 4 to 6 milliliters, you are looking at upwards of £1,500.
And the fat transfer is even more.
Right, if you opt for the permanent fat transfer, those surgical procedures start around £2,500. Which brings us to a really critical junction.
The regulation side of things.
Exactly. With high costs, soaring global demand, and the promise of a very lucrative new revenue stream, there is an obvious temptation for clinics to cut corners. If we step outside the rigorously controlled environment of those clinical studies, how strictly are these dosages actually regulated? Like, what happens when a practitioner just decides to ignore the math?
Well, if we connect this to the bigger picture, the reality is deeply alarming. Reports from the UK Parliament and the MHRA reveal a sector that is booming but dangerously underregulated.
It's basically the Wild West.
It really is. In many jurisdictions, dermal fillers are treated closer to standard consumer products than prescription medical devices. The Joint Council for Cosmetic Practitioners, the JCCP, recently issued a terrifying warning regarding the off-label use of these products.
Off-label meaning using the product in a way or in a volume that the manufacturer just never intended or tested.
Exactly. We just spent this entire time establishing that 2 to 3 milliliters per side is the scientifically proven, meticulously calculated limit for intimate fillers. But the JCCP found that unscrupulous practitioners are buying massive 10 milliliter syringes designed for facial contouring and utilizing them for reckless body augmentations.
Here's where it gets really interesting and, quite frankly, horrifying.
Yeah.
They aren't just bumping the dose up by a few milliliters.
No.
The reports state these unregulated providers are injecting over 1,000 milliliters of filler into patients for off-label procedures, like non-surgical Brazilian butt lifts.
Over a liter of a substance that biomechanically is meant to be maxed out in fractions of a milliliter.
That's insane.
The sheer physical pressure of that volume inside the human body is catastrophic. The JCCP cites multiple cases where this massive volume of filler resulted in fatal pulmonary embolisms.
Right, because the sheer pressure forces the filler into the deep vascular system where it travels to the lungs and causes a fatal blockage.
Yes.
It is such a stark contrast. The medical standard for augmenting the labia majora is this highly controlled, deeply respectful 2 to 3 milliliters per side. The danger clearly doesn't lie in the hyaluronic acid molecule itself. It lies entirely with providers who ignore the dosage limits and the anatomical science.
Which is why understanding the localized risks is paramount, even when practitioners stick to the proper dosages. The sources detail that with labia majora augmentation, patients will experience temporary swelling and bruising. But there are also risks of biofilm infections.
Oh, I noticed the surgical and cosmetic dermatology study cited a very specific kind of strange case regarding that.
The waxing incident.
Yeah. A patient developed a biofilm infection 14 days post-procedure, but it wasn't a sterile failure of the injection itself. She sustained a minor skin wound from waxing 2 weeks later, and surface bacteria entered the filler matrix.
Which was thankfully resolved quickly with oral antibiotics, but they also note the risk of cold nodules.
Which are what, exactly?
If the HA filler pools or isn't distributed correctly across those specific vectors we discussed, it can form small, hard lumps under the skin.
Oh, yikes.
Fortunately, these can usually be broken up by the doctor vigorously massaging the area to redistribute the product. But the ultimate critical danger in this specific anatomical region is intravascular injection.
Meaning accidentally injecting the filler directly into a blood vessel instead of the fat pad?
Exactly. The vulvar region is incredibly vascular. If filler enters a blood vessel, it causes immediate ischemia, blocking the blood supply, which leads to tissue necrosis or tissue death.
How do they prevent that?
The protocols mandate that practitioners must use blunt-tip cannulas instead of sharp needles. A blunt cannula pushes blood vessels aside rather than piercing through them. Furthermore, they must aspirate, meaning pulling back on the plunger before deploying the filler to ensure no blood enters the syringe.
You can't just guess where the vascular network is.
Absolutely not. It requires flawless anatomical navigation.
So what does this all mean for you listening? We've covered a landscape of incredibly specific clinical math today. We've learned that labia majora augmentation, far from being just a superficial trend, is a highly precise structural procedure offering profound functional relief for women experiencing tissue atrophy from aging or estrogen loss.
And we've established that the mechanism for safety and efficacy relies on strict dosage limits, typically 2.0 milliliters of specialized hyaluronic acid filler per side, capped at an absolute maximum of 3.0 milliliters per side in a single session.
Right. We've explored how specialized ingredients like mannitol protect the filler from oxidative stress and how the exact fractional milliliter mapping across the vulvar vectors ensures structural projection rather than lateral distortion.
And most crucially, we've seen the severe, sometimes fatal dangers that arise when that clinical math is abandoned in favor of massive, unregulated off-label dosing, which, raises an important question as we look to the future of our physical forms. If our bodies naturally metabolize these highly engineered hyaluronic acid matrices every 12 to 18 months, requiring continuous mathematically calculated top-ups to maintain this restored physiological function, are we entering a new era of human biology? One where our physical bodies are no longer permanent, naturally degrading structures, but rather lifelong, customizable subscription services.
Now, that is a wild thought to leave on. You don't just repair the bridge once, you maintain an ongoing fractional maintenance contract with your own biology.
Exactly.
Well, thank you for joining us on this deep dive into the math and science of cosmetic gynecology. We warmly invite you to keep questioning the world around you, keep learning, and join us for the next exploration.